So when we talk about respiratory distress syndrome, this is related to a delay in lung maturity. There can be respiratory distress of a non-pulmonary origin. This can be caused by sepsis, cardiac defects, exposure to cold, airway obstruction, hypoglycemia. So there are signs and symptoms that a newborn can present that are respiratory distress type symptoms, but they're not related to an actual lung or pulmonary condition or issue. So fluid is excreted through the alveoli. What happens is there is an unfolding of the alveoli septa, which increases the surface area of the lungs. This usually occurs in the last trimester. So you can see why if a baby is born premature or preterm and we haven't gotten to that state where we have the full development of the alveoli space in that surface area, they start to have issues with the surfactant. And they also are at higher risk for respiratory distress. The importance of surfactant is to inflate the lungs. There's some more signs and symptoms of respiratory distress syndrome on page 687, box 25-4. Most of the time these kids are tachypnic, they're short of breath. These are the kids that are flaring at the nostrils, they are pale, they have crackles, they are retracting in their chest. When there is inadequate pulmonary perfusion and ventilation, these newborns end up with hypoxemia and hypercapnia. If we have a prolonged episode of hypoxemia, this activates glycolysis, which ends up increasing our lactic acid in our body, which would cause the baby to be metabolic acidosis. They will do x-rays to confirm if this is a pulmonary issue or not. What is the treatment of respiratory distress syndrome? We want to establish airway and oxygenation. So we want to establish ventilation and oxygen, supportive care, and any kind of special measures that we may need in regards to a preterm infant. A lot of times we want ventilation, oxygen, maintain acid base. We want to maintain a neutral thermal environment because it's very important. Babies who are preterm already have lots of issues stacked against them or potential for high risk, but when we add an environment and they become cold or they end up with cold stress, this stresses them out and puts even more work on their lungs and their heart because they have no brown fat in order to keep warmth in them. We want to prevent hypotension, and we want to make sure that they have adequate hydration and electrolytes status. Typically with respiratory distress syndrome, nipple feeding or gavage feeding, and when I talk about gavage, it's just an NG tube for newborns. These are contraindicated. They typically put that on hold. They may do some form of TPN. They put that on hold because there is a risk for aspiration. Remember, we talked about just a term newborn has a lot of difficulty learning how to suck, swallow, and breathe all at the same time. So preterms definitely have issues with that. Surfactant can be given. It is actually given in an endotracheal tube. Nursing responsibilities if surfactant is administered is to assist the delivery of the product. They are usually the ones collecting the ABGs. They're monitoring oxygenation in the pulmonary sat and assessment. And typically, if this newborn needs to be suctioned, they try to delay it for 1 hour so that the max dose and effect of surfactant can be achieved. So what is NEC? And when I say NEC, I'm talking about NEC. It is necrotizing enterocolitis, which is at the very bottom of your screen. It's an inflammatory disease of the bowel and it is with increased incidence in preterm infants. The cause is still really uncertain. What happens is there's damage to the mucosal cell lining of the bowel, and this is usually significant. This decreases the blood supply, causing death, and it also stops secreting the protective mucosal layer. So you have a bowel that becomes unprotected. So when we have a bowel that becomes unprotected, then it starts to be attacked by a proteolytic enzyme, causing the bowel to actually swell and break down. Then it is unable to synthesize IgM. A lot of times with the newborns who have neck, and it tells you the clinical manifestations on page 695 in box 25-5, their abdomen is distended. There's blood in the stools. Usually there is localized abdominal wall erythema, lethargy, vomiting. They'll do an x-ray to confirm. They will do laboratory values, and they may find anemia, metabolic acidosis, electrolyte imbalance. In severe cases, your textbook says that they may find DIC or thrombocytopenia, but that's in the severe cases. Treatment of neck. We want to begin with prevention. So we can do oral feedings are withheld for at least 24 to 48 hours from infants who are believed to experience any kind of asphyxia during birth. Breast milk is preferred because breast milk actually confirms some passive immunity, that IgA, your macrophages, and your lysosomes. We want to monitor the newborns. We want to do assessment. We want to know that early clinical signs may be abdominal distension, gastric residual, and lethargy. There's some talk in your textbook about doing probiotics. This just helps reduce the incidence of severe neck. There's also some evidence shown that there should be standardized feeding protocols in regards to preterm infants.